Just sir, what do
Yes.
you mean by the blood conservation technique? Whether it is useful for us perfusionists or the other techniques are good, better than the blood conservation?
Nice question from your side. Blood conservation technique is the beneficial during cardiopulmonary bypass. Is beneficial for perfusionists, even the beneficial for the patients. So by applying the blood conservation techniques, there is so many methods of blood conservation techniques, which helped to reduction in blood transfusion. So if you are applying blood conservation techniques, especially with the patients like anemic patients, it is helpful. So there is so many ways to do the blood conservation techniques. Like number one is a wrap, retroautologous priming. Then we have a cell saver as a blood conservation technique. We are using a hemoconcentrator as a blood conservation technique. We are the patient who having the like in the beginning have a good hematocrit in the beginning, so we some of time we just take a 1 or 2 point prior to giving heparinize, and then we use the same whole blood for the patient for the better recovery. So I think blood conservation technique is one of the best and beneficial outcome for the patient's healing, and it is helpful to reduce the blood transfusion autogenesis, reduce the blood transfusions, so the patient required less donor's blood during the bypass. So especially the patients like anemics having the low hemoglobin hematocrit, so we can use the blood conservation technique and it is helpful.
So we cannot say that only wrap is good, only cell saver is good, or
No,
only
RAP have different benefit advantages. Cell saver have different advantages. Like in cell saver, you are just taking on the red blood cells. The rest of the clotting factor, plasma, sub all be going to be removed through the cell saver. But if you are using the hemoconcentrator, so it will be a very good, like you are just removing the extra fluid from the blood. So it's like a wrap. You are removing the crystallite fluid, which is in the priming mode. You can remove and replace with the patient's own blood. So they have the different advantages and different limited complications also. So we have to go through with all. So I think all techniques are good to save the patient's life, and it help to reduce the patient's donor blood transfusion.
so if it is good for the patient, all these methods we can use.
Yeah, we can
If
use.
it is not like this method is good, that
No,
method is
all
good.
have different advantages. So every technique of blood conservation is beneficial for the patient's outcome.
Yes, sir. So instead of using blood, if we use these techniques, it will be more beneficial.
Yeah, try to use less. Try to reduce the donor's blood. It is better to use the patient's own blood, and try to manage the patients during the surgery with the patient's own blood instead of using the donor's blood transfusions.
Only if emergency cases only we have.
Yeah, if it is very necessary or compulsory and there is no option, yes, you can go with the donor's blood transfusion.
So during every case we have to make a plan how to conserve blood,
Yeah,
how
there is
to.
there is criteria for RAP. There is a criteria for the cell saver. There is a criteria for usages of the hemoconcentrator. As you are the perfusionist and you know, there is so many criteria. So
Yes,
apply
sir.
the criteria and go accordingly.
So before every case we have to make a plan.
Yes. You have to do the pre-checklist. You have to do your pre-op assessment of the patient's coagulopathy, hemoglobins, and the body surface area of the patients. How much crystallite you require during the bypass circuit, and how much you can avoid the crystallite during the bypass circuit. So all this thing going to help as the pre-assessment, as you mentioned. So then you decide either your patient is coming in the criteria of blood conservation technique or not.
Yes, sir. So there will be no confusion
No
what to do that time,
Yes.
because you are already planned.
You are already planned, yes. It's better for the patient's outcome that you don't use the donor's blood.
Yes, sir.
So clear?
Yes, sir.
Thank you so much.
Thank you,
Is there any
sir.
question?
The question that I have is that so after pre-assessment also, even though we did RAP also, even though we did the filtration also, sometimes the HCT it will be not according
Coming
to like
up.
coming up.
Or is not in the mark.
Like not
a
in the
safe
mark,
side,
like
yeah.
not HCT is not 35, but it will be below sometimes in the end bypass time when we check. Why this happens, even though we apply all these techniques, sometimes it not every patient,
But sometimes
some
it is
only
you
one
know,
or two. If
You
we
know the blood transfusion or the transfusion of the patient is not only from the perfusionist side. You know the patient is managed by the anesthesia also. Sometimes in a surgical field they are using the normal saline for the ice slash, so which can lead more hemodilution. So sometimes although you did apply blood conservation technique, still sometimes they need to use some ice slash during surgery, or sometimes the post pump patients required some fluid because of the central venous pressure is not adequate. So they required some coagulator to manage the coagulopathy. Sometimes they use the like a FFP or PPF, or sometimes some factors and which are sometimes crystallized, so which can lead the dilutions more, and you may require to add a blood. So this can be the reason. So there is different reasons. Sometimes although you applied a blood conservation technique like a RAP, or you did a salt saver, or sometimes you did the hemofiltration, still you need to add a blood, because there is a difference. So many factors come up.
yes, sir. But whatever, we have to do our maximum. That is the
we
main.
try our best to do maximum as much we can to avoid blood transfusion from our side.
Yes, sir.
Okay.
Yes, sir. Thank you,
Have a
sir. For
nice and good day. Take care. Bye.
thank you, sir.
Bye.